Good afternoon. Good morning, everybody. I'd like to welcome you to today's webinar, Top Tips and Best Practices from the recent UCA Convention 2023. So this webinar is brought to you by EB Medicine and the Urgent Care Association. EB Medicine helps urgent care clinicians get up to speed quickly and easily and stay current on the latest evidence so you can feel confident treating your urgent care patients in the urgent care setting. Plus, we make earning CME credit easy and affordable. So my name is Jeff Owens. I'm a practicing physician assistant. I'm also an education consultant here at EB Medicine, and I'll be your moderator for today's events. So during today's presentation, everyone will be in listen-only mode. If you're unable to hear or see the presentation, or you're having any sort of technical issues, you can send a message through the chat, or you can visit ebmedicine.net/contact. If you have any questions for today's speaker, you can submit them at any time during the webinar or at the end during our live Q&A. You can use the Ask Us Question feature at the bottom of your screen. You can also uptick or upvote questions that you feel that the speaker should definitely address by clicking the arrow to the left of the question. So I'd like to thank EB Medicine and the Urgent Care Association for making this event possible. After the presentation, you'll get a brief demonstration of EB Medicine's latest resource, specifically for and designed by urgent care clinicians, called Evidence-Based Urgent Care. And if you stay till the end, you'll get a special bonus as well. This presentation will be recorded and available to all registrants within about a week. So now on to today's session. So I'd like to introduce you to Dr. Joseph Toscano. Dr. Toscano received his medical degree from Duke University School of Medicine in 1989. He trained in internal medicine at the Naval Hospital in San Diego and has been an attending emergency room physician at San Ramon Regional Medical Center since 1999, and he is currently chief of the department. Dr. Toscano has worked in urgent care since 2005. He was previously a partner at the corporate medical director for Pinnacle Medical Group, which operated urgent care centers in California and Arizona. In addition to caring for patients, Dr. Toscano works as a senior research editor for evidence-based or emergency medicine practice, and he's a member of the editorial board for the Journals of Emergency Medicine and the Journal of Urgent Care Medicine. He also develops and reviews continuing medical education for urgent care and emergency medicine for a variety of other publications and organizations. And he's currently the clinical content coordinator for the Urgent Care Association. Dr. Toscano is going to share with us the best takeaways from the UCA convention in today's webinar. He's going to present a rapid-fire redux of the most valuable points and pearls from the recent big event. The presentation is about 40 minutes in length. We'll have a live Q&A, followed by a demonstration of EB Medicine's evidence-based urgent care. So I hope you enjoy, and take it away, Dr. Toscano.
Thanks for the intro, Jeff. Let me do the screen share here. Okay. How's that looking? I have a little bit of a reverb on my side. I don't know if that is something from me or that everybody's hearing. I'm going to just turn down my volume. Okay, great. Well, it's my pleasure to be here today speaking to everyone about something near and dear to my heart, the Urgent Care Association Convention and its clinical content. What I'm going to try to cover in the next 40 minutes is the high points from over 20 lectures. I want to put in a plug for next year's convention. It's from April 13th to the 17th, 2024 in Las Vegas, Nevada, again at the Convention Center, Harris Convention Center, Caesars Convention Center. So it was a great venue, really comfortable place, but close enough that it wasn't very far to walk from session to session. So it's the ideal place to learn and network. So I'm going to get right into it. We've been hearing a lot about antibiotic stewardship for over a decade. And the next sort of medication I think that has been identified by experts as being overused in clinical practice is corticosteroids. And Bernie Short gave a great presentation a couple of years in a row. Last year was the first one, and then this year gave an update in terms of the best use of corticosteroids and how to avoid overuse. if you look at what steroids have actually been shown to be beneficial for and where the benefit exceeds the risk, there's only a handful of indications. The patient's insufficient of adrenal corticoids, like Addison's or Cushing's disease, um, some severe allergic reactions, asthma and COPD exacerbations. If the patient has a toxic pneumonitis or a true rheumatoid disease like RA or lupus or maybe nephrotic syndrome, a patient with traumatic or atraumatic cerebral edema, um, an organ transplant patient, a mom who was going to deliver a baby prematurely, and then Bell's palsy and gout. If you think about what we see in urgent care, only a few of these really apply to us. Maybe asthma, COPD exacerbations, Bell's palsy, and gout. Okay, screen advance. There we go. If you look at what the risks of steroids are, they include bony fractures, avascular necrosis of the hips. I think a lot of us are familiar with that. But one of the things that I learned from Bernie's lectures that I did not know is that venous thrombus and other thrombotic diseases is increased in patients when they use corticosteroids. I think we all understand that steroids decrease the immune system, but patients can have frank sepsis after steroid use. Also, GI bleeding and congestive heart failure are present in higher frequencies after patients have used corticosteroids. It's even the case that with inhaled steroids, you think not systemic, just delivered to the area where they need, there are higher rates of thrush, which makes sense, but also glaucoma and cataracts in patients who use inhaled steroids. It's important to keep in mind that the risk is cumulative. So even if you get away with it one time, the next time steroids are prescribed for a patient, the risk continues to increase. And you'll see differences in the risks and side effects of patients between those who are treated with steroids and not, with as little as a 500 milligram dose of prednisone or prednisolone cumulatively. So that's just a couple of steroid courses for asthma or COPD, a couple 5-day courses at 50 milligrams a day. Bernie cited an insurance database study with over 1.5 million patients, and they looked at differences in outcomes or incidences of certain problems in patients 5 to 90 days after corticosteroid prescription. And they found that the risk of sepsis, this is like frank sepsis, was 5 times higher in those who were treated with steroids. Venous thromboembolism was 3 times higher, and fractures were twice as frequent. So those are important to keep in mind and use steroids only when you need to. If you're not so concerned about that and maybe just concerned about your own well-being, corticosteroids are the 3rd most common medication involved in malpractice claims. So this spills over from the patients to the providers as well. And then he had a great recommendation, and that is to consider documenting a specific conversation with the patient about the risks of steroids when they are indicated, because those side effects occur even when they're being used correctly. And then actually including it in the discharge document that the patient signs. So to summarize, what we should not be using corticosteroids for in urgent care or in any venue is for acute bronchitis or sinusitis, just for the general respiratory tract infection if it's not in a patient with asthma or COPD. These are not indicated for allergic rhinitis or carpal tunnel. There's really no evidence to show that they work. Patients feel different, but they don't necessarily change the disease course. And so you're getting the side effects for really no real benefit. And then there's a couple of other indications that are maybe a bit more intermediate. There's insufficient evidence for the use of corticosteroids in acute pharyngitis, zoster, and radiculopathy. We'll be hearing more about this. I know this probably comes as a shock for a lot of people, and we'll be hearing more about this over time as our knowledge gets refined. It's becoming an area of focus for study and for education.
Dr. Toscano, if I can interrupt you just for a second.
Sure.
I think some people are still hearing the echo. If you could double check if you have Crowdcast open in additional windows, a lot of times that is the problem with echoes.
Okay, let me see. I think. How about, is that better?
I guess we'll see. I actually wasn't hearing an echo, but I know I was seeing a couple people internally and in the chat saying they were hearing one. So hopefully just let us know in chat if you're still hearing echo, but we'll continue and hopefully it'll be better now.
Okay, thank you.
Thank you.
I'm reluctant to turn my volume all the way down. I'll go down low. Here we go. Because if somebody needs to tell me something. Okay. Back to this. Okay. So Scott Kobner from Hippo actually gave a great talk about diagnosing urinary tract infection. This is something super common in urgent care medicine, of course. And it was actually pretty enlightening, I thought. It's something that's been treated over the phone by primary care physicians for a long time, and it's probably reasonable to do because if certain historical elements are present, it's reasonable to diagnose a urinary tract infection. If you look at the complaint of dysuria, it increases the likelihood of a patient having a urinary tract infection by 1.5 times, so positive likelihood ratio 1.5. Urinary frequency is even more accurate in terms of predicting urinary tract infection, 1.8. And actually hematuria, which doesn't happen very often with urinary tract infections, is a greater predictor that an infection might be present. When you start to combine these, then the likelihood ratio goes up even more. It's important when you consider the differential diagnosis of a patient who has urinary tract symptoms that certain things be excluded because there's overlap between vaginitis symptoms and urinary tract infection symptoms. So asking about the presence of a vaginal discharge or vulvar irritation is important, and those are pretty potent predictors when they're not present, that the patient has a UTI and that you don't have to dig further through that differential diagnosis. One of the things that we brought up in the learning lab was some of the emerging knowledge we have about acute MI. And I think everybody's familiar with STEMI and recognizing a STEMI on an EKG. But this is starting to crop up in the emergency medicine and cardiology literature, that there are some other EKG patterns that we need to consider as STEMI equivalents. And it's being termed obstructive MI, so OMI, instead of STEMI. And so I'm going to run through a couple of those just so that we'll begin to see those. This is relatively new stuff for the most part. So it's probably going to take several more sessions of us seeing it to get the pattern recognition down, but it's important for us to be aware. So this EKG is in a patient with chest pain, and it demonstrates something called hyperacute T waves. These are not the peaked T waves that we're used to kind of cluing into when a patient has hyperkalemia, but these are just big, plump T waves. And in this one, I've circled a couple of them. They occur, a couple of times in each of these leads. They're basically T waves that are almost as big as the QRS deflection. And when you see that, that's what's called a hyperacute T wave. And in a patient with chest pain, it is a STEMI equivalent. This is a good patient to get a serial EKG for maybe 10 minutes later. And a lot of times you'll see that hyperacute T wave actually turning into a STEMI. It's felt that this is an earlier pattern. You can kind of see some ST elevation in lead AB and in lead 3 here. So it's beginning that process. One of the other described patterns that's been around a little bit longer in the literature is Wellens syndrome. This occurs in the precordial leads. So you're going to be looking V1, V2, V3 for this. And it's a biphasic ST and T wave that's circled here. It's present in all of the QRS complexes, QRSTs in those leads, V2 and V3. But just to kind of clue in on it, it's where the ST segment is positive and then goes below the baseline and comes back up. Interestingly, these patients may have chest pain that's resolved, and the theory is that this is a reperfusion pattern. So the patient was having a STEMI or going to have a STEMI, and then our own natural thrombolytic agents, which we have, are clot-dissolving enzymes, actually partially lysed the clot, but not fully. So this is felt to be an example of reperfusion. It's considered a STEMI equivalent. This patient should not go home. They should not be put on any sort of a treadmill test. These patients typically go right to angiogram either immediately or soon after some further evaluation by the cardiologist and enoxaparin and other initial treatments. And then one of the other ones that I have actually some EKGs for to be able to demonstrate is the De Winter T waves. This is also in the precordial lead, so you're going to be looking V1, V2, V3 for this. I've just isolated the right half of the EKG because it's harder to see when it's smaller. But the changes are these real deep. I think we would kind of clue into this, that these are really deep ST segment depressions. To be a De Winter T wave, it only has to be about 1 millimeter depressed, but typically these are very depressed. They catch your eye. and it goes up into a tall T wave, almost like a hyperacute T wave combined with that ST depression. And again, I think though the ST depression, which catch your eye as an ischemic pattern, the more specific thing to know about this is it's a STEMI equivalent. So it's not just an end-STEMI patient, not the same as an end-STEMI patient. This patient's going to be treated in a more time-sensitive way. And then the most recent American College of Cardiology document summarizing the care of these sorts of patients actually described several other obstructive MI patterns, ST elevation in 2 of the inferior leads with a ST depression in AVL. We used to have left bundle branch block that was not known to be old as an MI equivalent or a STEMI equivalent for thrombolysis or taking a patient to the cath lab. That's kind of gone by the wayside because it's not super specific and it's a lot more common. But if a patient has a new right bundle branch block combined with a left anterior hemiblock, so a new bifascicular block, then that's felt to be a STEMI equivalent. AVR is the forgotten lead. It's good for identifying pericarditis, but also MI. And if the patient has a high degree of ST elevation in lead AVR, that's felt to be a STEMI equivalent. A lot of times they'll have changes in other leads as well, reciprocal to that. And then finally, the American College of Cardiology feels it's important for us to be able to recognize the isolated posterior MI. And these almost look like the De Winter pattern with ST segment depressions in V1 through V4, but they don't go over into V5 and V6. And in these situations, if you have that, you don't need to do posterior leads. That in and of itself is a worrisome pattern. So I'm waiting to get my own EKGs for these. The ones I have are all proprietary. So the folks from HIPPO summarized some medical legal pitfalls. You could give many lectures on avoiding medical legal issues in clinical care. And they focused on a few that were important and relevant to urgent care. And it does seem like discharge instructions are important when patients aren't instructed properly after a visit. If they don't follow up in time or don't recognize that they're getting worse, sometimes the burden for that reflects back to the provider. The literature on this, the legal literature, shows that there's not really any difference between written or computerized handouts. I think most of us are using, typing in the diagnosis or the symptom and handing the patient some paperwork about that. What is important, however, is that you make it specific to the patient. So it doesn't have to be handwritten. It can be typed, or you can have macros for these things, but it does need to include time and action specific information, like return immediately if worse, or go to the ED immediately if you're worse, or see your primary care doctor, not as needed, but if no better in 12 to 24 hours, or if the abdominal pain is not improved in 6 to 8 hours, then go to the ED. Those sorts of things are important. And as well, it's important to not only give that to the patient in writing, but also explain it to them verbally. In terms of medication use, even going beyond antibiotic stewardship, the use of fluoroquinolones is actually correlated with high rates of malpractice suits. And so the recommendation is to use fluoroquinolones, basically ciprofloxacin, levofloxacin, moxifloxacin, only in situations where there's really no other alternative, or they are the clear medication to use in that case, which is not too often. Maybe if you have a pseudomonal infection that you want to treat as an outpatient, then Cipro, Levaquin might make some sense. And similar to what Bernie Short talked about with documenting specifically risk-benefit alternative conversation for corticosteroids, it's actually was recommended that when you're prescribing fluoroquinolones for a patient, that you have a specific conversation with them about the risks of tendon injury. I have a macro for this for my discharge instructions, as well as prescribing it, as well as talking to them about it verbally. There was kind of an interesting segment about being recorded by patients, either the audio of the conversation or the audio and video. And I find patients doing this sometimes. I can't say it's been done when I've known and been hostile. A lot of times it's rationalized by them that they want to remember the details better. And in the olden days, it used to be the person who came in with a notebook and wrote down kind of everything we said because they didn't want to miss anything. And sometimes this is a good thing, but sometimes it can turn into something bad. I think we're a lot more conscious when we're being recorded. It's important to not necessarily refuse that unless you really know what your state law is regarding that. So all of us should know whether we have to let somebody record us, or whether it requires our consent, or whether we can refuse, and know what we feel comfortable with particular situations. And then finally, there was several examples of people, clinicians putting information on social media that got them in trouble. Not only, you think about this maybe being frustrated with a patient experience, but even maybe admitting a mistake on social media, that can come back to haunt you. So it's really important to be conscious of what we put on social media. Kind of going with that, Tracy Davidoff gave a great talk about how our charting can affect medical, legal, and other consequences. She gave 6 really good points. I think that if we think about it with each of our patient documents, the history and physical, and then I think we'll go a long way toward having good charts and protecting ourselves and documenting the vision well, documenting the visit well. Of course, the medical records more than just medical legal protection. So these things are important for continuity of care and letting people knowing what we think in the future. It's important to be aware of the vital signs at the patient check-in. If they're abnormal, it's important to kind of think about them and maybe even do something to change them if necessary. Recheck vitals if they're abnormal to make sure they're moving in the right direction. Not everybody has to have normal vital signs at the time of discharge, but they need to be improving if they were abnormal initially. It's important to address the chief complaint too. It appears in the record. Sometimes it's hard to find. I've worked with a couple different EMRs where you can see what's been documented as the reason for visit or the chief complaint, and other times where you have to dig around for it. But I've been surprised myself that you can talk to a patient for 5 or 6 or 7 minutes about something, and then go back to the chart and realize you didn't talk to them about the reason why they were there. And you go back and ask them, and sometimes they'll tell you that's not why they're there. So it's important to say that it was documented as a chief complaint that they had chest pain, but they don't have chest pain. Because it appears in the record, it's important to address it. Her next point was to think about what could go wrong. And I've seen this explained in a different way, and that is with each patient you see, to think about the 3 most common things in the differential, and then 3 really bad things that could be in the differential for the patient's presentation. And then go through in your mind that you don't need to worry about them because of certain risk factors, or do a test or 2 to exclude those 3 bad things. Templates, we're all using them. They can be very helpful for documentation, but it's important not to have a cookie cutter approach to that. So if you're using templates, make sure it's specific to the patient. Make sure it doesn't document more than what you did or asked, and that the abnormalities that are pertinent to the patient aren't on the specific visit. I'm going to talk a little bit more about clinical calculators and clinical decision rules, but when you use them, make sure you use them appropriately and document them appropriately. And then finally, not every patient needs to be re-examined after the initial time in the room, but if, again, somebody has abnormal vital signs or a treatment, like a breathing treatment is given, it's important to re-examine them and go back and document the change and hopefully the improvement. Ben Silverberg gave a great talk about sexually transmitted infections, the treatment of those, and the evaluation as well. These were summarized in an update in 2021. It's important to know that the IM dose for ceftriaxone, which used to be 250 milligrams for the various indications, urethritis, cervicitis, whether it was a documented GC infection or empiric treatment, it's gone from 250 milligrams to 500 milligrams. And if the patient's body weight is above 150 kilograms, to give them a 1 gram dose. Azithromycin resistance is increasing, so doxycycline is preferred. There may be situations for compliance where that single dose of azithromycin seems to be the right thing to do for a particular patient. It's harder to take 7 days or longer of a medication versus a single dose. But if you really want to eradicate the infection, it's important to understand that doxycycline is now preferred to azithro. For PID, it's recommended that patients with women with PID be treated with that IM ceftriaxone dose, as well as 14 days of both doxy and metronidazole. Speaking about metronidazole, the previous advisement that we used to give patients for not drinking because of that disulfiram reaction that could occur is no longer necessary. It does seem like it's a low frequency event, and it was a reason why some patients would not take the metronidazole. So the balance is to not necessarily mention that when you're advising the patient. Mycoplasma genitalium is an organism that I kind of think of similar to chlamydia, has a similar sensitivity. It's a similar organism that's kind of in between not really a bacteria, not really a virus, but a living cell that requires living cells to reproduce. And the incidence of that organism is on the rise. And that's important because there's really high rates of azithromycin resistance among that organism. So treating empirically with azithromycin, the patient's going to end up coming back with continued symptoms because it's unlikely to be treated. Doxycycline does treat this organism better. In situations where a patient does come back with an infection, it's possible to test for this organism. It's quite a bit more difficult. The organism is more fastidious and harder to grow and harder to test for. Sometimes it takes weeks for it to grow. I don't think they have a PCR test for this yet. And similar to a culture, you can actually ask for antimicrobial resistance testing if you're getting a culture for Mycoplasma genitalium. So keep that in mind if you have a patient who's returning with STI symptoms that don't seem to be getting better. In the past, Hep C and HIV screening was recommended for specific populations, and it still is recommended for specific populations in asymptomatic patients. But if you have a patient who's seeking treatment for an STI, it's recommended to talk to them and really push for screening for Hep C and HIV if somebody's seeking care for this problem. And that's for all patients, not necessarily specific subsets. Ben reminded us that herpes simplex is still a clinical diagnosis. There's a Zank, PrEP, and a PCR and blood tests that could be done, but they are really notoriously nonspecific and insensitive. So keep in mind, HSV is still a clinical diagnosis. If you see it and it looks like it or similar to it, it's reasonable to treat because the burden of that disease is high. I'm going to show a slide in a second with the United States and territories in terms of what the expedited partner treatment status is. It's authorized in almost all states now, so keep that in mind. And again, STI incidence is on the rise, and treating partners can help flatten that curve. Ben summarized a lot more information, and this is my wordiest slide, and it doesn't cover half of what he talked about. So you'll be getting the slides, and you could just go to the CDC and get the most recent treatment guidelines. It's a really important update. And this is the map of the US and some of the territories in terms of whether it's permissible to treat partners, and it's permissible in just about all states, not prohibited anywhere anymore. This was as of April 2021. There used to be a lot more yellow and red on this map in years past. Tracy Davidoff gave another talk on treating patients with community-acquired pneumonia. She basically summarized the 2019 IDSA and ATS guidelines. It's important because when you're looking at the X-ray, you can't tell whether it's atypical or typical organism, or if you're treating empirically without an X-ray. You have to risk stratify the patient for resistance to or the presence of resistant strep pneumo. That occurs at the extremes of age. The more comorbidities the patient has, like diabetes or immunosuppression, if they've had exposure to beta-lactam in the last 3 months, or kids in childcare, or exposure to kids in childcare, all of those things increase the chance that a particular community-acquired pneumonia in a patient is going to be resistant. If a patient has had exposure to antimicrobials, to any antimicrobials within the past 3 months, it's important to treat them with medication from a different class. Those medications are now, first line, amoxicillin 1 gram TID, so high dose amoxicillin. Doxycycline is still in that first line treatment in patients who have a penicillin allergy. The dose is 100 milligrams BID. For patients with any of those high-risk features on the other slide, those would be patients you want to treat with an extended spectrum. So you would use amoxicillin clavulanate or a second or third generation cephalosporin like cefpodoxime or cefuroxime, and add a macrolide to any one of those. So amox plus the macrolide, cefpodoxime plus the macrolide, or cefuroxime plus the macrolide to be able to get the atypical organism coverage. In certain situations, a patient might have risk factors for Pseudomonas. and still be able to be treated as an outpatient, or they may have a real strong allergy to penicillin or cephalosporin. And in those cases, that's where you're kind of painted into a corner to use the fluoroquinolone. It's reasonable to prescribe. Just make sure you're documented and describe the increased risk to the patient, but sometimes it's your only choice. The guidelines recommend treating for 5 days only and then reassessing a patient. If they're getting better or all better, they don't need any further antibiotics. So it's one of these shorter antibiotic courses that really work. And then finally, when you're trying to make the decision to admit the patient or send them to the ED or send them home, it's recommended that you use an objective scale. Sometimes a patient obviously needs to be admitted. They're frankly ill. And for me, more than going through this list and saying, oh, they have a 1 or a 2, I think in general, this substantiates the reason to admit them. Now, age is probably the softest one of these. You get a point for confusion, a BUN above 19, respiratory rate above 30, a low blood pressure, either systolic or diastolic, or age. And a lot of us don't have access to a BUN, so you could consider the clinical equivalent of the patient being dehydrated. But I will tell you, it's hard for me to send home a pneumonia patient who's confused, tachypnic, hypotensive. So I think any one of those is important, or dehydrated. Certainly age kind of comes in softer. The way the scale works is if a patient has a 0 or a 1, they can be safely treated as an outpatient. If they're 3 or higher, admission is really important. And in that range where they might have 2 of these, you could possibly treat them at home if they have good follow-up, or admit them. I think some of these are just worse than others. And for me, for somebody to go home, they need to have none of these, but they could be 65 or older, basically. The HIPPO folks talked about the use of clinical calculators, clinical decision rules. These are really working their way into our clinical decision making. And I think it's important, rather than thinking of them as a cookbook approach, to think of them as a way to objectify our decision making. They summarized the PCARN rule for head injury, the Canadian C-spine rule to tell whether you need an x-ray or not for a patient with a neck injury. The heart score and the clinical PORC rule, super helpful when patients come in with chest discomfort that's pleuritic or not. And actually, there's some new information on the horizon about the use of an HEAR score. A lot of us don't have access to troponin. It's been validated in certain settings, and there may be patients who you don't even have to get a troponin on if their history, their EKG, their age, and their risk factor profile puts them at very low risk to begin with. So we're looking forward to that being validated and useful for urgent care. The folks from HIPPO summarized several important papers. I'm going to go through these pretty quickly because I think this is taking me longer than I thought it was going to. I'll just summarize the high points. There was a paper that demonstrated that for kids with conjunctivitis, topical ophthalmic antibiotics help them get better faster. There was actually a very interesting paper about the use of high-dose cephalexin, double dose basically, instead of 500 QID, using a 1,000 milligram QID dose, and they found a lot lower rate of treatment failure. So it's actually very interesting. And sometimes you have a big patient. I always wondered whether we use the same dose for all adults. There were some higher minor adverse events, but actually fewer patients who needed to be admitted at the time of follow-up, 3.2% versus 14.2%. I mean, I would consider that significant. I think our knowledge is going to be refined about this. Maybe only a larger body weight patient or a patient with more extensive cellulitis needs that higher dose. And this was just recently published in January and was considered a pilot randomized control trial, but I think it's going to be important for us to look for more data on this. It might be something that would help us and help patients. There was a paper by Jonathan Edlow, who's a emergency medicine researcher with a special interest in vertigo. And they found that in patients specifically with BPPV, the use of meclizine or other vestibular suppressants was not anywhere near as good as doing an Epley maneuver or other canalith repositioning maneuvers for them. So if you think the patient has BPPV, not necessarily benign vertigo or vestibulopathy, but specifically BPPV, meclizine is probably not going to help them. They should really go through the process of the Epley maneuvers or repositioning maneuvers for the canalith. There was a paper in the Canadian Journal of Emergency Medicine that showed, and this was very interesting. I do this occasionally. Try to do this in urgent care. I'll do it in the ED sometimes when the risks of sedation or the hassle of sedation seems too high. Patient just ate or something like that. And that is to do an intra-articular injection of lidocaine. And in this study, they actually found no difference in the frequency of being able to reduce the shoulder dislocation between those two. And they had, of course, shorter lengths of stay and fewer adverse reactions if they avoided sedation, with no differences in the pain score. So this is something I'm going to talk to patients about and probably try to do a little more even in the ED. It's something, like I said, I've done a couple of times and it seemed to work, but it always just, I guess, seemed inferior to me. But the study was important, interesting that it showed that they weren't. And then finally, there are a lot of papers out in the COVID era during the pandemic that showed that studied zinc and other minerals and vitamins in terms of COVID. This study was done overseas, but they actually found that a dose of 25 milligrams of zinc twice a day for 15 days in admitted patients and patients who were treated as outpatients, 2/3 of them were admitted, resulted in lower ICU rates, shorter lengths of stay in the hospital, and overall decreased symptoms. So kind of interesting. Relatively recent paper. It may be that COVID, more severe COVID kind of comes back, and in that case, we can maybe consider treating patients with zinc in addition to whatever else is recommended at the time. And then finally, one of the HIPPO presenters, Josh Russell, who's the editor-in-chief of JUSM, did an interesting segment on one specific topic, and that is reported penicillin allergy or cephalosporin allergy. And he started off with a paper from the Journal of Asthma and Allergy that went kind of deeply into the immunology. And basically, the upshot is that the incidence of true beta-lactam cross-reactivity is low. So if a patient is allergic to penicillin, there's a really, really low chance that they're going to be allergic to a cephalosporin if they don't know that they're already allergic to a cephalosporin. Certainly, if the patient has had an anaphylactic reaction to penicillin, you're going to avoid it. But otherwise, it's low incidence. And a lot of patients have taken cephalosporins, and you can ask them and actually prescribe a cephalosporin for them. In a separate segment, Josh jumped into a couple of papers in another clinical calculator, the PENFAST rule, the penicillin allergy decision rule. And this basically summarizes the time since the FAST actually stands for an acronym 5 years or less since the last reaction, if they had anaphylaxis or angioedema or other severe reaction, and then was treatment required for their reaction to the penicillin allergy. And basically, you can come up with a score that puts the patient at high, moderate, low, or very low risk. And in situations where the patient is at very low risk, you can actually do a penicillin trial for them if penicillin's the antibiotic they need or something in the penicillin group. If someone is moderate or high risk, they should probably be referred for allergy testing before any penicillin or cephalosporin is prescribed for them. And then it's kind of a risk benefit in that low risk group. There's about a 5% chance of the patient being allergic to penicillin in those cases. Ivan Coe, who came all the way from London, actually reviewed several papers for us, which I'll go through quickly here. He actually does the abstracts review for the Journal of Urgent Care Medicine. And he summarized a paper that showed that the use of a soft wrap, something like an ACE wrap, was equivalent to a rigid splint in kids with torus fractures in terms of the outcomes. There was a paper that involved patients with prepatellar bursitis that seemed like it might be infectious. They treated some of the patients with empiric antibiotics and did aspirations on the others, and they did about the same, basically. It was a retrospective analysis, but it basically showed that you don't have to tap these. You can begin to treat with empiric antibiotics if the patient's not septic and requiring referral or admission, and your outcomes are just as good as going through the trouble to try and tap the bursa. There was actually an interesting paper that he summarized in JANA Network Open that was a very general viral test. It actually looked for a protein that are present in many, many different viruses called myxovirus resistant protein A. So rather than being a multi-panel to 16 viruses, let's say, this was a broadly applicable viral test. It came in a lateral flow cartridge, so similar to a pregnancy test or the COVID test, the home COVID test that we do. And they compared testing a finger stick blood specimen with that sort of a test to sending a full blood specimen to the lab and doing extensive antigen testing. And they found that it actually did fairly well. So this was sort of a trial of a new test that might be available to us in urgent care. Again, most of our diagnoses are clinical, but if you have a patient where you're on the fence, this is a test that when it comes on the market might be useful for us to help distinguish viral from bacterial infections. There was a paper from the European Journal of Emergency Medicine that talked about using something more than just a regular Valsalva maneuver in patients with SVT. The modified Valsalva maneuver includes having the patient begin with a 15-second typical Valsalva maneuver with a forced expiration, and then having the patient brought down to a supine position and having their legs raised about 45 degrees for 15 seconds. And this resulted in a greater conversion rate for SVT than just the Valsalva maneuver alone. So in situations where you don't have adenosine, regular Valsalva maneuver is not working for a patient, you could give this a try. The actually odds ratio of the patient converting from SVT was 4 times higher with this modified maneuver. Kind of easy because it includes the regular Valsalva in the beginning. So have the patient Valsalva. If it doesn't work, continue with the modification. And then the final paper that he summarized was the difference between just basically using tissue adhesive to close a wound versus steri strips to reapproximate the edges, and then using some sort of a tissue adhesive over that. They found no difference between the two, but it was a randomized trial. And in my mind, I think I will pull out the steri strips in situations where it's hard for me to reapproximate the skin. So it's not that all the patients get one or the other, it's that you use a little bit more selectively. But even in the randomized trial, they found that the treatments were equivalent. The folks from Hippo summarized treatment for pain management and not using opioids. And actually, there's excellent study data to support all of these in terms of treatment of pain. Starting simple with hot or cold application. And actually, for most soft tissue injuries, most people, although it's uncomfortable to move in the beginning, their pain goes down more quickly if the injury is mobilized. So not a fracture, but a soft tissue sprain or strain. They also show this, there's several papers that have shown this, that the combination of ibuprofen and acetaminophen together is almost equivalent to opioid analgesia. Newer topical NSAIDs are coming on the market. I'm surprised when patients bring in things that they're using, and there's topical ibuprofen now and diclofenac, but also the lidocaine patches and also topical capsaicin, good data, sometimes for only certain indications, so it's important to understand those. But all of these are good adjuncts for pain control and can help avoid an opioid prescription. For patients with dental pain, it's good to know a dental block or two. There are some simple ones to just numb a particular tooth, or broader blocks that can be used, nerve blocks that can be used if multiple teeth or there's a traumatic injury. And then finally, in patients with migraine headache, and I've done this a couple times and it actually works pretty well, to learn how to do an occipital nerve block. It's just a couple of injections in the occipital area. They're pretty good anatomic landmarks to know where the nerve is. There's really, really low reported incidence of any problems with this, and it can be a useful adjunct in that migraine patient who has a refractory headache if you want to avoid opioids. There was a talk, actually a couple of presentations on the treatment of vertigo. And I think to summarize this, I wanted to talk about a very reasonable and safe and appropriate clinical approach. It's important to evaluate the patient for central signs early. Really, the thing we're worried about is a posterior circulation event or posterior tumor that's become symptomatic. And although it's not always possible to see if the findings are subtle, we should at least look for these. Any patient that complains of diplopia or difficulty swallowing or has frank ataxia, if you do a finger, nose, finger, or heel, knee to shin test, test their gait. These are the patients that'll actually, sometimes I'll see a patient walk in or walk out, but these are the patients I actually have stand up and walk around. Oftentimes patients with vertigo that's peripheral may kind of lean to one side, but if the patient has a frankly ataxic gait, that's a bad sign. And then anybody who can't sit up unassisted, who has to kind of stabilize themselves, call that truncal ataxia, those are all signs that the patient's dizziness is more likely to be central versus peripheral, you can stop right there, and that's a patient that has to go to the ED for imaging. In my own practice, I'd have to say almost all vertigo is benign, but a smaller subsegment of patients tend to have BPPV, where they feel fine at rest. They have pretty severe symptoms when they move their head, and then it stops when they stop moving their head. It's a kind of an intermittent triggered type response. In those patients, I will usually do the Dix-Hallpike maneuver to confirm it, and then you can go right from the Dix-Hallpike to the Epley maneuver to begin to treat it. It doesn't always work that first time, but that's how you can confirm the diagnosis. In my experience, almost the vast majority of patients that I see with vertigo in urgent care in the ED have some other vestibulopathy, vestibular neuronitis, or something other than BPPV that's still benign. And it was practice changing for me to learn how to do a HINTS exam. You can go on the internet and Google HINTS exam and see this. The more you do it, the more comfortable you feel with it, and it's super, super useful. The first thing that you do is look at the patient's nystagmus. If it's benign and peripheral, the nystagmus should only be horizontal and only in one direction. If you have the patients, when you're testing their extraocular movements, have nystagmus in both directions, or if there's any vertical nystagmus, that's a bad sign. You can stop right there. Patient needs to go to the ED. Test of skew is extremely simple. You have the patient fix on your nose, you cover one eye and then uncover it and do the same thing on the other. There should be no deviation of the eyes as you uncover. If there's specifically a vertical twitch or vertical movement of the eye as you uncover, that's a central sign. Patient needs to go to the ED. And then finally, head impulse testing. You have the patient relax their neck and you turn 10 degrees and come to center and do the same thing on the other side, 10 or 20 degrees, or you can start centrally and then go 10 to 20 degrees in either direction. And when you go in the direction that correlates with the ear that has the vestibulopathy, the patient will actually have some what looks like nystagmus, but they're called catch-up saccades, where the eyes try to catch up to the perceived movement that the canal thinks is continuing. So it's hard to go into it any further than that right now, briefly, but if you look up HINTS exam, super, super useful to help you be assured of a benign diagnosis. Sorry about my dog. Benign diagnosis in patients with dizziness. And then this is just a summary. To be assured of a peripheral vertigo type event, the patient should actually have nystagmus. It should be vertical and unidirectional. There should be no eye movement on the test of skew, and then they should have catch-up saccades with head impulse test. And the presence of all of these has actually been shown to be more sensitive than an MRI to determine posterior circulation ischemia. So it's actually difficult to see that even on an MRI. This was super interesting. The Hippo folks talked about cellulitis as, particularly in the age of antibiotic stewardship, something that's overdiagnosed and overtreated, particularly in the legs, commonly confused with stasis dermatitis. They reviewed a study that showed that of all the patients that they observed, this was an observational study, who were treated, and actually a lot of them admitted to the hospital with cellulitis, 84% of them did not need to be admitted, and 93% of them received unnecessary antibiotics. That was unbelievable to me. To hone in or to fine tune your diagnosis of cellulitis, there is a scale called the ALT-70 scale. And again, you can see there, it has to do with some vital sign abnormalities. The white count we don't always have access to, but if you remove that and the patient has a score of a 0 or a 1, it's unlikely that they have cellulitis. Of course, the higher score they have, the more likely they have cellulitis. I would say for me, if a patient comes in and both of their legs are red and it looks like they have a pretibial cellulitis, but it's bilateral, it's really unlikely to be cellulitis. It's a lot more likely to be stasis dermatitis. There's a score on ND Calc too that you can go to help with this rather than memorizing it. There were a couple procedure pearls I want to go over. For nail bed injuries, the era of us getting out the 6-0 Vicryl or other absorbable suture and meticulously closing the nail bed is now gone, thankfully. You can try to just reapproximate the tissue as well as you can and dermabond that injury, and they do as well as suturing those. It's important to put something back down that holds it flat, ideally the native nail that's been cleaned, put into the the proximal nail fold and then secure down. Actually, the dermabond will hold it down, and then dermabond around the nail folds to hold it down as well. But that works really well for nail bed injuries. Similar outcomes and a lot easier and a lot more quick, obviously. Patrick O'Malley gave a wound care talk, and one of the cool things I thought he talked about was this corner stitch, also called the horizontal half-buried mattress stitch. I think when a patient has a V-shaped wound, our usual inclination is to stitch right across the point of that, but what tends to happen is it necroses off that tip and you get a triangular area of scab or necrosis. And this is a stitch that goes under the skin, half buried through the apex, and then comes out the other side, and then the stitch is tied here, and it really well approximates that skin edge, and you don't get that necrosis. Matthew Shores talked about shoulder reductions, and actually several of these can be done without sedation. When you do that intra-articular lidocaine, it makes it even easier. But scapular rotation is an interesting technique where you basically try to hold the patient's scapula. You rotate it when you're looking at the right scapula, let's say from the back, in a clockwise direction, and it moves the glenoid into an area that allows for an easier reduction. Sometimes that in and of itself can reduce the shoulder. It can be used in combination with the Stimson or other techniques. He talked specifically about the Los Davos technique, where you basically tape the patient's wrists together, have them put it on their knee. I don't know if you guys can see this, and then lean back. And actually there's a fair, because the patient is controlling it themselves, it tends not to be super painful. The Fairs technique is a technique that involves taking the patient's arm, starting it in a position of adduction, and shaking their hand at about a 2-second shake rate, and gradually abducting the arm. And then if you apply a little bit of external rotation, that actually works fairly well. Again, no IV sedation needed. If you do the intra-articular lidocaine, it helps. And then if you Google chair reduction, it basically involves turning a chair so that the side of the chair is under the patient's arm, cushioning it, and then a little bit of a manipulation on the arm. It applies both some outward movement, and do a little bit of a rotation with that, and has a pretty high rate of reduction. And again, it's something that can be done in urgent care and doesn't require any sedation. And then Brian Sun, who's an oral and maxillofacial surgeon, gave a great talk on treating a variety of oral and maxillofacial injuries and other infections. And one of the most frustrating things I find is a patient who's on an anticoagulant and has some sort of bleeding from their mouth. You can try an injection of lidocaine with epinephrine. I found that to be actually successful if there's just one area of bleeding. When it's bleeding out over a wider area, it's a little bit more problematic. But tranexamic acid comes in both a liquid or a tablet that can be dissolved, and either the 4 or 5% solution that's available, or making a solution with the tablet, having the patient swish that out around in their mouth for a couple of minutes and then spit. They can do that once or twice, and it actually really reduces the bleeding. So it's a useful tip. I think I'm getting close to the end. I'm going to talk real quick about epistaxis. I just have 2 more slides. And it's important not to rush to do nasal packing, to have the patient apply pressure to the nose, do the things that are least invasive and least painful to the patient. And if it works, you can stop at that point. So, always make sure the ABCs are under control, have the patient apply pressure. And if that's good enough, if they've already applied pressure multiple times and it's not working prior to coming into the clinic, then obviously you got to do something more. But if in the clinic it stops with pressure, most of the time you don't have to do anything more than that. And then there's increasingly aggressive treatments according to that algorithm there. And then finally, the HIPPO folks talked about diabetic foot ulcers. There are a variety of lab tests that can help us make a decision as to whether the patient needs to be admitted. But in most cases, if you feel comfortable sticking a small sterile probe into the ulcer, if it's greater than a couple centimeters and the x-ray shows some findings, those are patients who need to be referred. If it's a small ulcer where you can't even see the bone, let's say, or can't pass a probe to the bone, those patients can be treated as outpatients. All right, I think we'll go to some questions. I'm going to turn my volume back up.
So thank you, Dr. Toscano, for that presentation.
Great.
It was truly excellent. And again, thank you to EB Medicine for hosting this event. So now it's time for some questions. From our audience, you can submit a question under the Ask a Question tool at the bottom hand of your screen. You can also vote for other questions that you would like to see answered. So we're waiting for some questions to come in. Can you talk a little bit about, or if you have any tips or points or pearls for how you document the use of those clinical calculators, the Curve 65 and your Canadian C-spine rules, things like that?
Right. So usually how I do it is in my history or exam, I will describe the specific findings and then summarize it in my medical decision making. Say, the patient has PERC rule is easy. It's either positive or negative. So you have a patient with pleuritic chest pain, you run through the indicators. Age is important, and that's obvious. But if they have a swollen leg, have they had VTE before? Do they have a history of cancer? Has there been prolonged immobilization? Then you can just say negative clinical PERC. For the heart score, I'll usually say what the score is. That one I memorized. We use so much. I would have to say when I'm using the PCARN rule, sometimes you kind of have a sense that the PCARN rule is negative because there's nothing wrong. But I'll go back to that. That's one that I'll actually call up and go through and just check through each one of them to make sure I've asked all the questions, and then just say the patient's low risk by PCARN. And that's actually turned into a MIPS, the CMS MIPS clinician quality rules. They actually want us to say low risk by PCARN, so the patient doesn't need a head CT. That covers a lot of things. That covers your risk management, basically. You're validating your decision not to refer the patient for imaging or do the imaging. You're checking off the MIPS box, and you're also, I think just in general for communicating, saying that you've assessed the patient that they're low risk.
Great. So it looks like we got a question. What vasoconstrictors do you like to use for epistaxis?
So yeah, this is interesting. I use tranexamic acid. Oh, so actually vasoconstrictors. I usually use oxymetazoline or epinephrine. So I'll back up. Oxymetazoline would be the thing I would try first. Afrin nasal spray, basically, if you want to consider the brand name. You can also use neosynephrine. Those are the two that are kind of most common. And a patient could use that at home when they have a nosebleed. But we use a lot of times when we're evaluating the patient because the decongestion that it gives lets you look in their nose better. A lot of times the bleeding will stop with that. And if it does, you could talk to the patient about just using that periodically if they have rebleed, combining that with pressure, and then you might avoid that next step, which would be cautery. If neosynephrine or oxymetazoline aren't working, then you need to do something more aggressive. That's when you would attempt some cautery or something more aggressive. Now, tranexamic acid, I'll just go back. I kind of blurted that out. There was a 2 or 3 year period where it appeared that tranexamic acid on a cotton pledget, you could put that in a patient's nose and it really helped. Now that's a thrombotic agent, basically. It helps blood clot. It's not a vasoconstrictor. It's used intravenously, actually after heart surgery. It's used sometimes in major trauma, given systemically to decrease bleeding. And this is a topical use that was described. A lot of us were excited about it because in terms of this stepwise approach, you could stop if the tranexamic acid worked and you didn't have to do anything more aggressive. There was a paper that came out a couple of years ago that showed that it was no better than saline. And so a lot of us stopped using it, but there was a more recent, actually very good review that shows that it works. And so I'm going to start using it again. I think it just came out a month or two ago. So I have to grab the paper and take a look at it, but it seemed like it worked. I mean, you always have to be careful about your anecdotal experience compared to, really a really good trial and a controlled situation to know that what you're doing helps and doesn't cause any harm. But I think probably the best trial to date recently came out. Again, I have to read it, but that's another thing that we'll probably add into our algorithm.
Great.
I see something. I see a question. Please clarify LH and LR. I know LR was in the presentation as a likelihood ratio. So that means if you, it's a little more complicated than this because you have to use a nomogram, but it's a statistical term that basically says if you, prior to your application of that criterion, if you think there's a chance of something happening and the likelihood ratio is 1.5, that means the chance of it basically goes up 50%. So if there's a 70% chance you think something's happening, and then you add that thing with a likelihood ratio, that feature with a likelihood ratio of 1.5, you can roughly say now there's, what did I say, 70? Now there's a 85% chance that that thing is going to happen. So the higher the likelihood ratio, the more positivity it adds to the discriminatory value of that element. And that's a positive likelihood ratio, and then a negative likelihood ratio decreases the chance of it. And those are negative likelihood ratios are usually there's a minus, but then it's less than 1. So 0.03 means it goes down by 3/100ths. And that's a very good negative likelihood ratio. That kind of helps you rule out something. And then positive likelihood ratios help you rule in. I don't know what LH was. Might have been a typo. Sorry.
All right. Well, thank you for answering those questions. So that's all the time we have for questions today. We're a little bit over time. And I still need to and would like to walk you through the demonstration of evidence-based urgent care. So if you'd like to continue this discussion, you can visit our blog at ebmedicine.net. So for the last 10 minutes, I'm going to talk to you about evidence-based urgent care. And I will start to share my screen as well. All right, so what is evidence-based urgent care? So evidence-based urgent care is going to be a monthly journal to help clinicians who are committed to lifelong learning. Those clinicians who are looking for a partner or a mentor as they have experience ongoing education throughout their career. Our mission at EB Medicine is going to be to help clinicians integrate that evidence-based clinical decision-making into their clinical practice. We do that by having expert physicians review all of the evidence on a given topic, combine that with their clinical experience, review all of the evidence, combine it with their clinical experience, and present you with practical recommendations that you can use and apply to your next shift in an urgent care. Each monthly issue is going to focus on a single topic that's going to be relevant to your urgent care setting. It's going to be written and peer reviewed by clinicians who are practicing in urgent care, so you know it's going to be relevant to your practice setting. Your subscription is going to include access to all new issues as well as a library of our old issues. Each new issue comes with 4 CME credits. So let's jump into the website so you can see an active issue here. So on our home screen, if we click Browse Topics, we can filter by evidence-based urgent care. And here you're going to see all of the available issues. And all of our content can be accessed on the website or through our mobile app. You can print and save a copy. Print the PDF and save a copy of each issue as well. So first, let's dive into an issue here as soon as we can get up the evidence-based urgent care. So looking at our April issue of community-acquired pneumonia. So if you're short on time, you can jump right to the points and pearls section. Here you're going to cover a summary of the key points for each issue. It's going to give you the must-know information in just 60 seconds. When you're ready, you can dive into the full issue. And here you're going to be presented with practical evidence-based recommendations that you can use on your next shift. We follow a consistent format each month, so you can quickly find information that you're looking for. So let me get back to it. So we're going to follow a consistent format each month so you can quickly search and find the information that you're looking for. Each issue and article is going to start with case presentations. We're going to cover real life scenarios to help you identify those high-risk patients and atypical presentations that you might encounter. There's going to be a table of contents accessed on the left-hand side of your screen where we can quickly navigate through each issue and through the article. So after a brief summary of the epidemiology and pathophysiology, we jump into the urgent care evaluation, where you're going to find practical recommendations for patients in the urgent care setting. We're not going to cover things that you already know. We're going to focus on high risk, commonly missed presentations and conditions, and give you quick access to the best practices and key takeaways. Our diagnostic studies section is going to cover the lab test or imaging options that you might consider paying close attention to those that may or may not be available to you in an urgent care setting. So back to the table of contents. So each issue is also going to cover controversies or special circumstances or populations, again, focusing on those practical takeaways. Our goal is for each issue for you to learn something new that you can take with you to your next shift. A favorite of a lot of our subscribers and readers are the risk management pitfalls. So these are going to be presented as excuses that don't really work in court. These potential pitfalls are going to help you avoid costly mistakes in managing your patient's care. Of particular interest to those of you that might be medical directors or CMOs or really anyone who has to worry about the bottom line, in addition to providing excellent patient care, is going to be our charting and coding tips section. This section outlines some simple changes that you can make to your current documentation and your current practice to make sure that your clinic gets full reimbursement for all the services that you're providing. Each article and issue is going to consist of at least one clinical pathway. It's going to give you this easy to follow algorithm for patient care. And a lot of our subscribers use these as a basis for protocols in their clinics. Oftentimes they're printed out or laminated and kept in the provider workstation. A unique feature of all of our pathways is that they're going to include the level of evidence that each recommendation is based off of. We're also going to include a critical appraisal of the literature within each edition. We review hundreds of articles to create these courses. You're going to find a summary of the quality of evidence on the topic at the end of each course, and this is truly evidence-based education at its best. At the end of each article, you'll be presented with a reference list, and one of the unique things about us is that we're going to include all of the references cited, specifically the information and the type of study, the number of patients, giving you additional insight into the evidence that we're using. So really that's evidence-based urgent care in a nutshell. Get back up to the top. So one thing that makes us unique at EB Medicine is we're focused on helping you retain the information. The content's going to be provided to you in multiple different formats. We're going to include those points and pearls with that 60-second summary in the beginning. You're going to have the clinical pathways and risk management pitfalls that I mentioned. We'll also include postscripts that you can work through at the end of the article to help reinforce that learning. When you're ready, you can take Click CME test to obtain your 4 CME credits. So to summarize, kind of what makes evidence-based urgent care is different than the other resources that are out there and available. So we're laser focused on that practical application to help you learn and retain the knowledge. It'll improve your patient care, increase your confidence, and improve the bottom line of your clinics. This is something that's really designed to be read off shift in preparation for your next shift in the urgent care setting. So I hope you enjoyed the overview of evidence-based urgent care. So we're offering all of you a special treat for joining us on this webinar today. You can use the promo code webinar to receive 20% off of your evidence-based urgent care subscription. So this offer is limited time only, so act fast. I'd like to thank again everyone for joining us today. A big thank you to Dr. Joseph Toscano for being our expert today and providing us with a terrific presentation. We really appreciate the time you put into putting everything together. So you'll receive an email with a link to the recording within a week. You can post additional comments and questions on EB Medicine's website. Thanks again for attending, everybody. Don't forget to take advantage of the 20% discount using the promo code webinar. So to exit, you can simply close your browser. Have a great rest of the day, and thank you.
Thanks, everyone.